very excited to be talking about the beneficiary experience in rural communities. I'm the VP of Policy at Better Medicare Alliance, and glad to see you all again from the pre-lunch session. But I'm very happy to be joined by Bill Finerfrock, who helped co-found the National Association of Rural Health Clinics and ran that organization for many years, with Kristen Lunde, who works for ATI Advisory and previously worked for the Senate Finance Committee, and Duana Patton, who works for the Ohio District 5 Area Agency on Aging. And so we're going to start with Kristen, and ATI Advisory has done research into the Medicare Advantage rural beneficiary experience and looking at various data elements and the financial impact on rural beneficiaries who are in Medicare Advantage plans. And I'm going to turn it over to Kristen to present some of this information that they've analyzed.
Great. Well, thank you so much, and thanks for having me. Looking forward to sharing some data with you all that hopefully can do some stage setting for the conversation, and share some interesting insights based on beneficiary data and differences that we see, and similarities between the Medicare Advantage and the fee-for-service population in rural areas. So we'll start with just a quick overview of ATI Advisory, a little bit about our methodology, and then some key takeaways, as Don mentioned, related to things like enrollment, demographics, care experience and utilization, as well as cost. So ATI Advisory is a research and advisory services firm. We are based here in DC, and we work with a variety of clients in the managed care space, post-acute care and hospital providers, as well as state governments, other policymakers. And really, we do a variety of engagements around strategy, market assessments, and policy analysis, as well as data analysis, which will be the focus of our time here today. So the Better Medicare Alliance engaged us to take a look at a couple of different data sets, and to look at differences between the experience of Medicare Advantage and fee-for-service beneficiaries. So I'll start with telling you just a little bit about the methodology for this work and where the data is from. And I will say there's a public data brief that's available with all of these findings as well on BMA's website. So if you have questions about any of the detailed methodology here, or want to find any of these figures after the session, that is available. So we looked at the Medicare Current Beneficiary Survey and the Master Beneficiary Summary File, which are two of the kind of key data sources that the Medicare program makes available, and contain information on kind of detailed demographic and care experience, as well as enrollment variables for both the fee-for-service and Medicare Advantage population. And so you'll see these data sources cited kind of throughout the presentation. I'll note the data that we're looking at here for the beneficiary survey information is going to be from 2017 through 2020. That file is a little bit less frequently updated, so that information is just a little bit older, whereas the enrollment data from the beneficiary summary file is going to be from September of 2023. So starting with just a high-level kind of summary of where Medicare beneficiaries live, the graph that you see here is the overall sort of total Medicare population, and you can see the categories that we've utilized throughout our report across the bottom of the screen. So we have urban areas, rural, large towns and cities, and then smaller isolated rural towns. And so for purposes of this analysis, when you hear me say rural area, that will be what's highlighted in gray here, or the sort of smaller isolated rural town category. So as you can see, the majority of Medicare beneficiaries are located in an urban area, with kind of just about even split between the large towns and cities and isolated rural towns. There is an interesting split, though, between the fee-for-service and the Medicare Advantage population. So Medicare Advantage enrollees are 30% less likely to live in a rural area than those who are in fee-for-service Medicare. And just another note here on kind of how we're defining rural areas, because that is an important call out, and different parts of the healthcare system define that rather differently. So we're using the RUCA codes here, or the Rural Urban Commuting Area codes. This is what the Federal Office of Rural Health Policy utilizes, but I'll note that it is different than some other parts of the Medicare program, which utilize census-based metropolitan definitions. So just a distinction there to call out. So moving to some key takeaways from our analysis, starting with enrollment. So this graph here shows the number of Medicare Advantage plan choices by geographic area. And I think, as folks might anticipate, the urban areas have the highest number of plan choices available at 45. Again, this is 2023 data. But I think, interestingly, we see the rural and large rural city areas having high numbers of choices as well. 27 plans is quite a variety of options for beneficiaries who are located in rural areas as well. Looking at demographics, so some interesting findings here. We see that the prevalence of a variety of these demographic attributes is quite similar, actually, across Medicare Advantage and fee-for-service when we're looking in rural areas. So we looked at things like having chronic conditions, living alone, being food insecure, or having difficulty with activities of daily living. And you can see those percentages are quite similar across the Medicare Advantage and fee-for-service beneficiaries that are living in rural areas, with some slight differences, the largest being related to food insecurity, and a higher percentage of Medicare Advantage beneficiaries experiencing that situation. Where we see a larger divergence in the data is related to race and ethnicity. This is 2023 data, and what we see here is really patterns that are true across the full Medicare population, playing out kind of similarly in the rural population. So Medicare Advantage beneficiaries are about 3 times as likely to be Black, more likely to be Latino than their fee-for-service Medicare counterparts, and fee-for-service Medicare beneficiaries are more likely to be white. So, and those kind of generally match the patterns that we see in the overall Medicare population as well. Now moving to care experience and utilization. So this data is available through the current beneficiary survey, and there's a lot of great information there about how beneficiaries feel about their experience with the Medicare program and the care that they receive. And I think this is a really interesting kind of look at the feedback that we get from beneficiaries. So quite similar numbers, again, across the board, interestingly, for MA and fee-for-service. And so we called out here kind of 3 different metrics of access, being satisfied with ease of getting to the doctor, satisfied with healthcare quality, and satisfied with medical care on nights and weekends. The ease of getting to a doctor is the one finding here where there was sort of a statistically meaningful difference in the data. So we see that MA beneficiaries in rural areas are more satisfied with ease of getting to their doctor than fee-for-service beneficiaries. I'll also call out that we did look at data on care utilization in rural areas. We haven't included it here, but it is included in the full data brief. And I think that's a really interesting space as well. We saw kind of similar rates of ED and outpatient utilization, but slightly higher rates of preventive care utilization among Medicare Advantage beneficiaries. And I think this is a space that we're likely to see more research in. Those who follow the Medicare Payment Advisory Commission meetings may have seen they recently put out sort of a rural work plan for the coming year, and looking at access and utilization by sort of MA and fee-for-service enrollment is on their agenda. So I think an interesting area to watch there. And then finally, touching on cost. And I'll also say here, BMA and ATI have done work together looking at beneficiary spending more generally outside of just sort of the rural and urban comparison. We put out an annual brief that looks at out-of-pocket costs on both premium and healthcare spending. And again, we see sort of a similar pattern play out here among rural beneficiaries as we do the total population, which is that beneficiaries who are in fee-for-service typically spend more money out of pocket on an annual basis than their Medicare Advantage counterparts. I think interestingly here that we see that difference sort of play out more significantly in the large town and urban space. So meaning that MA beneficiaries and fee-for-service beneficiaries are spending more similar amounts of money on an annual basis in rural areas, and have a more drastic difference in their spend in urban areas. So kind of an interesting statistic there. And then you can see when we look at likelihood of being cost burdened, that is sort of a metric of how much of a beneficiary's income is spent on healthcare costs in a given year. And we see sort of the dynamic flip there a bit, and that is likely due to the percent of beneficiaries who report being at or under the 200% of the federal poverty level. So that rate is higher in rural areas for MA beneficiaries, and so we see their likelihood of being sort of burdened by their healthcare spending is higher, even though they're actually spending less on their healthcare than their fee-for-service counterparts. So that is the end of my slides, and happy to take any questions that you had, Don, or elaborate on any of that.
So, in going over this data and stuff like that, was there anything that really surprised you about what you found, or the sort of the experience of rural Medicare beneficiaries, be it MA or in fee-for-service?
That's a great question. So I think I would say that access to care findings are the fact that they are really quite similar between Medicare Advantage and fee-for-service is really interesting, and it I think speaks to the fact that rural beneficiaries, potentially regardless of their choice in terms of how they get their Medicare coverage, probably are facing some of the same barriers to care that we know rural beneficiaries have, things like transportation, availability of providers in rural areas, workforce shortages, things like that. And so there are a variety of factors that are really outside of the coverage decision that really will impact beneficiary access to care. So would just highlight that, and I think really speaks to some of the work that we've seen, MedPAC and CMS and others do to kind of look at availability of care and really look across the total Medicare population.
It's very interesting data, but it's not just the data, it's also about the experience of beneficiaries, and wanted to ask Duana, the area agencies on aging are obviously an excellent resource for older beneficiaries, those with disabilities, to help connect them with local resources. What are some of the unique opportunities and challenges that beneficiaries are dealing with in rural areas that you engage with them on?
Thanks. I think some of the unique opportunities in rural areas, and probably in the urban areas too, but it is something that we think about in our network, and that is the availability to utilize telehealth. And so, transportation was mentioned, and just access to care sometimes is a challenge. And we talked about caregivers earlier, and just having the availability of someone to even take someone to an appointment. But when there is telehealth in the home, we do find that care sometimes is delivered quicker, or things are identified faster in the home than, perhaps if that wasn't available to them. So I think that's a great opportunity to just utilize telehealth more. And then just working with, I think there's a lot of opportunities for beneficiaries to work with local organizations to help them navigate some very complex systems that are out there. So I think those are two of the greatest opportunities that exist.
In dealing with Medicare beneficiaries, whether it's Medicare fee-for-service, but especially Medicare Advantage beneficiaries, have you found any type of unique things in dealing with them and navigating their care or their needs?
I would think probably from that perspective is those that are on the Medicare Advantage plans, and Kristen alluded to the cost associated with that. I think for them, just access to care and the ability to afford the care that is available to them is often an opportunity. And then again, just the access to the additional services that a Medicare Advantage plan might provide to them.
What would you think are some of the common things that benefit? You'd mentioned telehealth and transportation, but presumably beneficiaries are engaging you because they have some type of maybe issue. Is it mostly, I can't find a provider, or is it, what are some of the common issues that they're engaging you on?
So a lot of times it's not necessarily access to the service, but the timely access. So what we have seen is, people, individuals in rural areas sometimes have to travel afar to get that service. And if their plan requires them to see the physician first, their PCP first, and then get referred to a specialty care doctor, that lag time in access to care can really be imperative and a detriment to them. So a lot of times we're helping work with them to maybe find that care somewhere else if they need to, if time is of the essence. So helping them navigate maybe transportation that is available to them so that they can get the care. We just recently worked with a gentleman that he could not wait to access a specialty doc in his area because they only came so often. And so we worked with him to get him transportation and an appointment in a more urban area where he could get that care more timely.
I think that's a very important point, and the AAAs play a very important role in helping beneficiaries navigate the system. But of course, it's not just beneficiaries that we're dealing with in the rural areas, but also healthcare providers in rural areas who have their own sort of unique experiences, and that's why we asked Bill to join us up here. And what role do you think Medicare, and by extension Medicare Advantage plans, have to play in regards to dealing with rural healthcare providers?
Well, they're critically important. One of the things about rural communities is that the payer mix in a rural community is often different than the payer mix that you would find in an urban or suburban area. And in particular, you find that Medicare and Medicaid are much more significant players in those communities. So anything that affects Medicare payment, positively or negatively, can have a disproportionate impact on those rural providers and their economic viability. And so I think we have to be particularly sensitive to the fact that they cannot afford to lose money by seeing Medicare patients or also Medicaid. I know that's not part of our discussion here, but it's really important that the payment models that are available to them cover the cost of providing care to those patients.
Well, and when we think about Medicare Advantage plans in rural areas in particular, how do you think that the providers in the MA plans are interacting nowadays?
Not a lot. I think there's a lot of skepticism on the part of rural providers about Medicare Advantage. The patients find it attractive for the reasons that Kristen has identified, low cost, low out-of-pocket expenses, but at what cost to the provider? And so many providers don't feel that the way that they are going to be compensated by the plans is going to be sufficient to cover their costs. So if you look at a rural health clinic or a critical access hospital, for example, they get cost-based reimbursement from Medicare. And the reason they get cost-based is that the Medicare program is trying to ensure that what they are getting from the Medicare program covers the cost. And I know that's an amazing concept, that you would get paid enough to cover the cost of providing a care to a particular patient population, but that was the purpose. A managed care, a Medicare Advantage plan comes in and says, well, we want to pay you differently. Or, well, we'll pay you your cost per visit rate, but we don't want to do a cost settlement at the end of the year. And they look at that as going, well, wait a minute, I'm going to lose money. You know, you're not actually covering my costs. The other thing that I think we have to recognize is, and this is out of the realm of primary care, but when it comes to ER and OB services, there's a tremendous amount of downtime where, you know, they're on standby. And there's no way within the current methodologies to really pay for that standby time. So if we want ER services, if we want OB services in these rural communities, we have to look at the idea of, well, who's paying for all the downtime when they're not actually having an OB patient, the ER doesn't have a patient, but we want to sustain that in much the same way as we want a police force or a fire department. We don't pay them on a per visit, per encounter basis. We recognize that there's going to be a lot of downtime. You know, I have a fire station that's a couple blocks from my house. The guys live there, the women live there, but how many calls a day do they have? But we want them there when we need them, but we pay for that standby time. How do we pay for standby time in these smaller rural facilities?
You know, I think if you went back many, many years and asked, you know, healthcare policymakers many, many years ago, they would have said rural providers probably are in a stronger negotiating position when it came to MA plans because of network adequacy requirements and things like that. But today that doesn't seem quite to be the case. What do you think has changed over time to shift that balance? Is it just greater enrollment in MA plans and rural beneficiaries, or is there more to it, you think?
Well, the one thing I was curious about with Kristen's data, she at the outset identified populations in rural, urban, large rural, small rural, and I think the N was somewhere in the neighborhood of about 10 million people, but yet at the outset of this session, they said it was 1.8 million people are enrolled in rural beneficiaries enrolled. So that's like, what, 18%? Which is a very small percentage of individuals who live there, and the other 92% are presumably in Medicare fee-for-service. So I think we have to be somewhat careful when we do the comparison that, you know, we've got an N of 8.2 million people versus an N of 1.2 million people, and then to compare them, there's a reason, I think, why a lot of those people aren't in Medicare Advantage. Some of them is beneficiary, but I do think the provider still has a lot of influence over the decision. So while it has increased, I don't think we're seeing the kind of Medicare Advantage penetration in rural communities. Certainly in rural communities where CAUSE and rural health clinics, those smaller rural communities are prevalent, I don't think you're seeing as much Medicare Advantage penetration there.
So you raised a very interesting point, and I'm not sure we necessarily have any answers here about, like, you know, ER, OBGYN specialties. You know, what are maybe some of the measures, or what else do we need to think about in delivering healthcare in rural communities?
Well, one of the things I would say that folks need to think about is that the workforce that is typically available in a rural community is different than what you might see in an urban area. So, for example, the question that was put out in the survey was, you know, ease of accessing a doctor. Well, was the question, do you have access to a doctor, or do you have access to a healthcare professional? Because very often in those rural communities, the health professional they have access to is a physician assistant or a nurse practitioner. So if you ask the beneficiary, what is your ease of access to a doctor, they may say legitimately, not very good. But that doesn't mean that they don't have access to a health professional who's fully competent and capable of providing good quality care. So I think we have to also recognize that there may be a different workforce that's out there. And so when plans are looking at contracting, who's in network, what are your policies with regard to contracting with PAs and nurse practitioners and not just doctors, and making sure that we're doing surveys or asking questions, we're asking questions about the diversity of the workforce that's available in those communities.
So I want to open some of the next questions to all the panelists if they would like to chime in. But, you know, I think all of us here have sort of hit upon some of the hurdles, but what are some of the other hurdles you think that are out there in delivering care to rural communities?
I'm happy to jump in. I think, we mentioned them briefly, but certainly I would say things that we would call sort of the social determinants of health. I mean, of course, they impact urban beneficiaries as well, but there are some, things like transportation in particular, but other needs that might be going unmet. You think of access to healthy foods or a grocery store on a regular basis. And so, there's a variety of those needs that, of course, impact health status, and, are particularly relevant when talking about the Medicare Advantage market because, these plans have the flexibility to try to meet some of those needs through supplemental benefit offerings and other flexibilities. And so, I think that's a particularly interesting space to think about when it comes to communities and how, what the opportunity would be for Medicare Advantage plans to kind of to target those needs based on geographic kind of area and specific needs of a community.
And I would just add to that, just the prescription drug provision of that. Many, pharmacies are closing, and so we literally have pharmaceutical deserts, in rural areas where it is very challenging for individuals to get access to their medications. And so, I think sometimes that becomes a barrier, including the costs associated with that. But at the area agency, then we're able to, again, help them connect to a pharmacy in their area, perhaps a mail order pharmacy that would be available. But many times we'll see people that'll, just tell us, I don't have transportation to the pharmacy. So therefore I am not getting my prescriptions as I should. And so then we have those issues that we deal with. We are fortunate enough that we do contract with a couple MA plans, and we provide a care transitions individual that goes into the home. We do the medication management. We help connect them to the local resources. And so I think it's just, everybody's needs are different. And, healthcare is local, whether it is or not. And so I think from our perspective, at the community-based level, working with the social determinants of health, trying to find what are those barriers to access, whether it's healthcare or medications, is helping them overcome those through, services and supports that are available in the community.
I think one of the great advantages for Medicare Advantage, if you will, is you have the ability to be innovative, right? You're not constrained by the policies that have existed and developed in the Medicare program for decades. You have certain requirements. Basically, you have to ensure that the benefit package that is available to beneficiaries in traditional Medicare are available to beneficiaries who are enrolled in your plans. But beyond that, I don't feel like you've taken the opportunity to be as creative as you could be when dealing with things like, oh, we don't have a pharmacy, we don't have transportation. Telehealth has now become, a popular solution. And while there's a role for telehealth to play, it is not a substitute for the ability to have a provider in the community. But look at how you can be innovative. Look at how you can be creative and work with the providers in those communities to figure out how can we solve some of the dilemmas that you're confronting and using payment models that can help support that. I feel like sometimes, at least early on, maybe it's changed, but the idea was, well, they're just small urban. So whatever we develop for an urban market, we'll just make it scalable for a rural market. No, they are different. And even within the rural market, rural Ohio is different than rural Montana, is different than rural Iowa, is different than rural Virginia. And so while we put them all under the basket of rural, the reality is that there are hundreds and hundreds of unique circumstances, and use your innovation to be able to try and tease out what some solutions to those might be.
Well, I think you raised some very interesting points there, Bill, and wanted to just sort of wrap up here by saying, whether it's Medicare Advantage plans or CMS with Medicare fee-for-service, what do you think would be the biggest impact thing that they could do to help beneficiaries in rural areas? I mean, I think, Bill, you've mentioned some, be sort of interested in what Duana and Kristen might have to say.
I would think, from my perspective, I think it would be education. but not necessarily just education to the beneficiaries, but educating families, community-based organizations. You know, one of the things that we do at the area agency, and many area agencies across the country do this, is we are the front door to services and supports for long-term care. And that means helping individuals navigate the enrollment process. So not only do we just meet with them and help them during that enrollment process, we also then are there for them when they need access to services. And maybe that is looking at their plan and seeing what's available, or if the plan doesn't provide it, what's available in the communities. But I think Bill is right. I think what's really exciting about MA plans is the ability to be innovative. And that's exactly what has happened in, you know, in some of our parts of the state, is where the MA plans are relying on the community-based organization, the area agency in this case, to, you know, go into the home. Because just as things, you know, and health happens locally, it really happens in the home. And a lot of folks have talked about social determinants. And so, you know, I think that's where there's opportunities too, is to think about beyond just the healthcare part, but the social determinants.
Yeah, would definitely echo that. I think a few other thoughts on the supplemental benefits piece related to, you know, some of the recent rulemaking that CMS has done in this space. You know, I think there are opportunities that plans can take advantage of to really make sure that beneficiaries are aware of the benefits that are available to them. So there's, you know, new requirements that plans sort of notify beneficiaries when they have an unused supplemental benefit. The sort of responsibility for demonstrating evidence around supplemental benefit offerings has shifted to the plans as well. And so I think, you know, an opportunity for plans there to sort of think about what are the specific beneficiary populations who are utilizing these benefits, and what is the impact that it's having, and how does that relate to their geographic location. And then just to pick up on a point that you made, Duana, around long-term services and supports, you know, I think we haven't talked much about this in this conversation, but, you know, a lot of Medicare Advantage plans may be offering dual eligible special needs plans. And so thinking about, you know, those beneficiaries who do require long-term services and supports, what are the opportunities to really better integrate and coordinate that care with Medicaid benefits and the Medicare Advantage benefits that they're receiving. So I think that's another area of opportunity I'd highlight as well.
Well, I really appreciate everyone's comments. This is a very difficult area, I think, dealing with rural beneficiaries. And I think as the years progress, probably more will be joining MA plans, and these issues will continue to be out there as CMS and others like the AAAs engage with them. Thank you.
Thank you.